أعزائي طلاب المرحلة الخامسة كلية الطب جامعة واسط. عنوان المحاضرة بريتام ليبر. معكم الدكتورة اريج صباح. Definition: in a pregnancy, a term refers to the gestational period of 37 plus 241 plus 6 weeks. That is term. Regarding a preterm birth, occur between 24 plus 0 and 36 weeks plus 6 days. So the prevalence of preterm delivery is 7.4%. Early birth occur either due to spontaneous preterm labor or preterm pre-labor rupture of membrane, which is known as P-PROM, or due to indicated deliveries. Each one of those account for 1/3 of early birth, of preterm birth. نجي على causes of preterm birth. Number 1, cervical weakness. Cervical weakness classically associated with painless premature cervical dilatation. And this is suggested by what? By history of painless second trimester pregnancy. There is a strong relationship between cervical length and the risk of preterm delivery, and also a previous history of cervical surgery is a common risk factor for cervical weakness. يعني common risk factor for cervical weakness is the presence of history of previous cervical surgery. Regarding infection of the fetal membranes, known as chorioamnionitis. So, chorioamnionitis is infection of fetal membranes, is a major cause of preterm birth. In most cases, the infection is ascend from vagina, although the route of infection may be transplacental or introduced during invasive procedure. But the main cause is ascending infection from vagina. Number 3, as a risk factor for preterm labor is multiple pregnancy and uterine distension. About 56% of multiple birth deliver before 37 weeks. يعني تقريبا أكثر more than half cases of multiple pregnancy delivered before 37 weeks, and 10 to 15% before 32 weeks. Polyhydramnios, the presence of too much amniotic fluid, يعني increased amount of amniotic fluid, increase risk of preterm labor and P-PROM. Although the effect is not as great as in twin, with a preterm delivery occurring in between 7 and 25% of fetus depending on the degree of polyhydramnios. Number 4, we have uterine Mullerian anomalies. Congenital Mullerian anomalies are often unrecognized but are estimated to occur in up to 4% of women with reproductive age, and this will lead to abnormal formed uterine cavity. Uterine anomaly are associated with adverse pregnancy outcome as a P-PROM and preterm birth. And here there is a number of uterine Mullerian anomalies. We have unicornuate uterus, bicornuate uterine diadelphy, and septated uterus and arcuate uterus. Number 5, we have hemorrhage. Antepartum hemorrhage and a placental abruption may lead to spontaneous preterm labor. A patient had antepartum hemorrhage. This condition may lead to spontaneous preterm labor. In early pregnancy, presence of subchorionic hematoma also increase risk of later PPROM. يعني patient have in early pregnancy subchorionic hematoma is a risk factor for later PPROM, either through an effect of thrombin on membrane strength or through the occurrence of infection when in the hematoma. Acute bleedings lead to release of thrombin that directly stimulate myometrial contraction and then lead to initiation of preterm labor. Number 6, we have stress. Both maternal or fetal stress as FGR, fetal growth restriction, may be associated with preterm labor. The biochemical pathway through which the maternal and fetal stress promote preterm labor is uncertain, but may involve a premature increase in circulating corticotrophic releasing hormone. Corticotrophic releasing hormone has a major role in initiation of labor. Management of preterm labor. Diagnosis of preterm labor. Diagnosis of preterm labor is by testing of cervicovaginal fluid level of fetal fibronectin. يعني in the cervicovaginal fluid we test the presence of fetal fibronectin. What is the fetal fibronectin? Fetal fibronectin is a glycoprotein when موجود found in cervicovaginal fluid, amniotic fluid, placental tissue, and the interface between the chorion and the sedua. So it acts as a glue at the maternal fetal interface, and its presence in the cervicovaginal fluid between 22 and 36 week gestation has been shown to be a predictor for preterm delivery. يعني إذا لقينا بالcervicovaginal fluid fetal fibronectin, so it is a predictor for a preterm delivery. It has a very high negative predictive value. يعني absence of fetal fibronectin in cervicovaginal fluid, so this means there is exclusion or high exclusion for the presence of a preterm labor. So most women with threatened preterm labor and negative fetal fibronectin test to be sent home, while those with positive fetal fibronectin test can be admitted for tocolysis and steroid for fetal lung maturation. خلينا نيجي نحكي على التوكوليتكس. The role of tocolytics is to allow a course of steroid for fetal lung maturation to be completed and to facilitate transfers of the undelivered mother to a unit able to provide appropriate neonatal care if the delivery will occur. يعني the role of tocolytics is only for completion of the fetal lung maturity by the effect of steroid, and also allow transfers of undelivered mother to a unit that provide neonatal care. tocolytics اللي ممكن ننطيها للبيشنت هي بيتا أجونست، رايتودرين أو سالبيوتامول اللي هي هم نسميها بيتا 2 ستيمولانت. شنو الأكشن مالتها؟ شنو الرول؟ is relax smooth muscle associated with significant، لكن هي associated with significant life-threatening maternal side effect especially if given in combination with corticosteroid. يعني هي صح تفيدنا and decrease uterine muscle contraction، لكن أكو life-threatening maternal side effect. مثل إيش؟ مثل fluid overload، pulmonary edema، myocardial ischemia، hyperglycemia and hypocalcemia and maternal death from acute cardiopulmonary compromise. لذلك احنا البيتا اجونست قدر الامكان avoid it in pregnant women. And also its side effect increase in women with multiple pregnancy. Another tocolytic is non-steroid anti-inflammatory drugs, which is indomethacin, which may significantly delay the preterm delivery for 24 to 48 hours and for 7 days. It's a major effect of indomethacin is upon the fetal renal function and fetal cardiovascular system, in particular on the fetal ductus arteriosus. So there is higher incidence of necrotizing enterocolitis, intraventricular hemorrhage, and abnormalities in neonatal hemostasis. Number 3 of tocolytic, magnesium sulfate is inhibit uterine contraction and reduce the risk of cerebral palsy where in the surviving infants. So magnesium sulfate has a role on as a tocolytic and also improve and decrease the risk of cerebral palsy in surviving infants as the preterm baby or preterm fetus has a high risk of cerebral palsy comparing with term delivery fetus. نجي على الأكسيتوسين antagonist اللي هو أتوسيبان and also there is calcium channel blocker as nifedipine. All these are tocolytic only to delay or decrease the uterine contraction in order to permit action of steroid on improvement or completion of fetal lung maturity. احنا هنا عندنا معلومة كلش مهمة انه الستيرويد ينطي between 24 and 34 weeks. That means before 24 we do not need to give it to the pregnant women, and above 34 also we do not urgently need to give it to the pregnant women with preterm. Antibiotics. Use of prophylactic antibiotics in uncomplicated preterm labor before 37 weeks with intact membrane didn't confer any short-term neonatal benefit. Long-term follow-up شافوا significant increase in the neurodevelopmental handicap in those who receive either erythromycin or co-amoxicillin. Erythromycin has been adopted as a treatment of choice for PPROM. For PPROM only. It's not given to women with a preterm labor and has no sign of infection. هسه نجي على البريترم premature rupture of membrane اللي هو نسميه PPROM. PPROM هو شنو؟ rupture of membrane prior to the onset of the labor. ف preterm PROM ونسميه PPROM is the rupture of membrane that occur prior to 37 weeks gestation. Incidence of PPROM is 2% of all pregnancy are complicated by PPROM. It forms about 1/3 of preterm labor, as we said before. 50% of women delivered within 1 week. Being 50% of those patients with PPROM will deliver within 1 week, and 75% will deliver within 2 weeks. The earlier in pregnancy that PPROM occur, the shorter the interval to delivery. Now regarding the diagnosis of PPROM is by history. Patient give history of gush of fluid vaginally, followed by continuous drop-off. Also give history of reduction in fetal movement in strength or frequency after PPROM. Also, there is uterine irritability or contraction may be reported. On examination by pulse rate assessment, temperature, and abdominal examination may reveal a clinical suspicion of oligohydramnios or uterine tenderness مش وقت هذا بحالة الكوريوميونيتس development. Definitive diagnosis of BPROM is by sterile speculum examination. راح نشوف pool of amniotic fluid when in the posterior vagina, and may also there is a dilatation of cervix can be assessed. مثل ما نشوف هنا بالصورة there is a dilatation of cervix and this is a bulging membrane. Digital vaginal examination should be avoided if possible. Investigations for BPROM is nitrazine testing. بس أردكم تنتبهون وتفرقون بين investigations for preterm labor اللي كان fetal fibronectin test and the testing for diagnosis of BPROM which is nitrazine test. Amniotic fluid is alkaline. Vaginal secretion are usually acidic. So an elevation of pH, this will lead to turn nitrazine stick to black color. False positive also may occur when there is a blood contamination or semen or urine. So this will limit its usefulness. But the nitrazine test has high negative predictive value. نجي على genital tract swab, high vaginal swab, and screening for group beta streptococcus can also be performed. Maternal well-being. This should include regular assessment of mother's blood pressure, pulse rate and temperature, and also serial white BC count and C-reactive protein as they are regarded as early markers for infection. اللي هو شنو هو الانفكشن؟ chorioamnionitis. Fetal well-being assessment by serial antepartum cardiotography after BPROM as a gradually increasing in the baseline heart rate or what we call a fetal tachycardia can be first sign of intrauterine infection. يعني احنا شي يفيدنا CTG and fetal assessment of well-being إنه إذا starting to become tachycardia, so it is regarded as a first sign of intrauterine infection. Ultrasound, the presence or absence of oligohydramnios, there is a direct correlation between the amount of amniotic fluid remaining and the latency period. يعني كل ما كان amniotic fluid amount is more, so the latency period will become more. And when the amniotic fluid volume is less, so the latency period is less. Amniocentesis by getting a sample of amniotic fluid and sent for gram stain, microscopy and culture. Why? To establish whether there is an intrauterine infection, which we call chorioamnionitis, or not. Complications of BPROM. هذا الموضوع جدا مهم. عندنا maternal complication chorioamnionitis اللي هو شنو infection of amniotic fluid membranes, endometritis, sepsis, all these complications for the mother, and postpartum hemorrhage. Fetal complication, prematurity, fetal complication of BPROM, prematurity and sequelae, intraventricular hemorrhage and necrotizing enterocolitis. Number 2, pulmonary hypoplasia following BPROM occur approximately 50% of women with BPROM at 19 weeks, falling to about 10% at 20 weeks gestation. يعني كل ما كان BPROM earlier كل ما كان risk of pulmonary hypoplasia in the fetus is more. Also, there is deformities and contracture due to decrease in the amniotic fluid volume, and there is a risk of neonatal sepsis. زين نيجي على هسه management of PPROM is by admission to hospital. Management must balance the risk of prematurity if delivery is encouraged versus the risk of maternal and fetal infection if delivery is delayed. يعني it means that when we get a decision about the management, we should balance the risk of prematurity against what? Against the risk of maternal and fetal infection. So the PPROM at 34 weeks plus or to 36 plus 6 days. The management is by expeditious delivery. Group beta streptococcus prophylaxis should be given. In this gestational age range, there is no significant data to support corticosteroids for fetal lung maturity. يعني in this gestational age is better for expeditious delivery and prophylactic antibiotic for group beta streptococcus infection should be given, and there is no significant data support giving steroid. يعني in this gestational age there is no significant data for that support corticosteroid for fetal lung maturities. نجي على PPROM at 34 to 24 weeks. In the absence of clinical sign of infection، يعني patient إذا ما عندها signs of infection، بهالحالة management يكون by expected management. خلال هاي الفترة there is a daily assessment of maternal and fetal well-being. Antenatal assessment. Maternal, the criteria for diagnosis of clinical chorioamnionitis شنو هي maternal pyrexia, tachycardia, leukocytosis, uterine tenderness, malodors, vaginal discharge, and fetal tachycardia. So, in maternal assessment, we assess these criteria. Frequency of maternal and fetal assessment اللي هي شنو هي temperature, pulse rate, fetal heart rate, auscultation should be between 4 to 8 hours، يعني كل 4 إلى 8 ساعات assess the maternal well-being. Regarding the fetal assessment, electronic fetal heart rate tracing is useful. ليش؟ Because the fetal tachycardia is sign of fetal infection and chorioamnionitis. Corticosteroid reduce the risk of respiratory distress syndrome in PPROM, but there is controversy. Use of antibiotic associated with significant reduction in chorioamnionitis. 10 days of erythromycin has been adopted as a treatment of choice for PPROM in many obstetric units in UK. However, concerns have been raised over widespread use of broad-spectrum antibiotic for all patients with PPROM. Use of tocolytics. Tocolysis is contraindicated due to the increased risk of maternal and fetal infection in patients with PPROM. After PPROM, didn't increase the interval between the membrane rupture and delivery or reduce neonatal morbidity. Delivery. Timing of delivery, diagnosis of chorioamnionitis, spontaneous labor, death of fetus, cord prolapse, abruption of a placenta, or demonstration of fetal lung maturity. These are indications for termination. Route of termination will depend on the urgency of the indication, as, for example, cord prolapse, which is common in PPROM. The previous in cord prolapse is indication for cesarean section. need urge termination of a pregnancy. Previous cesarean section also may need to termination by cesarean section. Presentation of the fetus, يعني that means that the route of termination depend on the presentation of fetus, depend on the number of fetuses and presence or absence of labor. مثلا نجي على موضوع آخر اللي هو prediction of preterm delivery. Prediction of a preterm delivery depend on past obstetric history. Patient give a history of previous preterm delivery, increase the risk of preterm labor and a subsequent pregnancy. 4 times comparing to a woman who had a previous delivery at term. Ultrasound measurement of cervical length. Cervical length measured by transvaginal ultrasound has been showed that it's more accurate than trans-abdominal ultrasound. يعني assessment of cervical length is done by transvaginal ultrasound, not by abdominal ultrasound. And there is a direct relationship between the cervical length and risk of preterm delivery. So the cervical length surveillance with serial measurement of cervical length throughout the second and early third trimester is now used to monitor women whom at risk of preterm delivery. مو أي patient. The patient at risk for preterm delivery إحنا نعتمد على a transvaginal assessment of cervical length. إيش وقت نبدي بيه؟ throughout second trimester and early third trimester. هنا هاي صورة مثل transvaginal ultrasound to assess the cervical length. هنا cervical length start to decrease and there is appearance of funneling of the cervix here. Combination of cervical length and obstetric history give us a prediction about 80.6% of extremely early spontaneous preterm delivery and 10% screen positive rate. And the combination of cervical length or obstetric history, the prediction value in. How can we prevent preterm delivery? Number 1, by progesterone. Progesterone has been known to be important in maintaining pregnancy for more than 8 years ago and thought to be promoted. How can prevent by promotion of uterine cohesions and inhibit the production of pro-inflammatory cytokines and prostaglandins within the uterus. Vaginal progesterone may prevent preterm birth. Also, cervical cerclage, transvaginal cervical cerclage may be placed in 3 different circumstances. احنا راح نشرحها. Number 1, following multiple mid-trimester losses or preterm deliveries. يعني patient عندها history of multiple mid-trimester loss or history of preterm deliveries. فإذا هذا شو نسميه؟ نسميه history indicated cerclage. Number 2, when the cervix shortens, usually less than 25 mm in women with history of cervical surgery or previous preterm birth. هنا شلون حددنا هذا length by ultrasound. So it's known as ultrasound indicated cerclage. هنا اعتمدنا على الهيستوري، هنا اعتمدنا على الالتراساوند. Number 3, when the cervix is dilated in absence of contraction, and this is known as rescue cerclage. نجي على الميكانيزم by which cerclage help in prevent or delay preterm labor. is not entirely understood, but likely, however, that circulation provides structural support to a weakened cervix and enhance cervical immunological barrier by improving retention of a mucous plug and preventing ascending infection by maintaining cervical length. There are many roles for cervical cerclage in prevention of preterm delivery. And similar to progesterone, cervical cerclage doesn't appear to reduce the risk of preterm delivery in multiple pregnancy. يعني in multiple pregnancy شافوا إنه cervical cerclage will not prevent risk of preterm. ليش؟ لأنه risk of preterm delivery in multiple pregnancy is high. So the different types of cerclage are described in McDonald transvaginal cerclage, which is transvaginal purse string suture inserted in cervicovaginal junction without bladder mobilization. And number 2, Schwartz, which is high transvaginal cerclage. It is purse string suture inserted following a bladder mobilization. هنا أكو bladder mobilization to allow insertion above the level of cardinal ligament. Also, there is transabdominal cerclage, which the suture is inserted in the cervico-isthmic junction via laparotomy or laparoscopy. Transabdominal cerclage can either be inserted preconceptionally or in the first trimester of pregnancy. هنا McDonald cerclage procedure for incompetent cervix. Here is a modified Schwartz cerclage for incompetent cervix. And this is mercenary tape, which is used in cervical cerclage. Thank you very much.